So any questions about anything we covered last time? This is where we're going to get into the nitty-gritty of kinetics and getting into how these drugs are actually getting processed throughout the body. So we'll get with this stuff. We're going to talk about ADM and E. It's basically it stands for absorption, distribution, metabolism, and elimination. So those are big concepts we'll talk about regarding the kinetics of the drug specifically. We'll talk about things like loading doses, steady states, and how we get toxicity from these. So we'll cover. Okay. So again, remember what was the difference between pharmacodynamics and kinetics?
Dynamic is what drug does to the body.
Yeah, dynamics is what the drug does to the body. Kinetics is what the body. Perfect. Yeah. So again, that's what we're going to be focusing on today. So the big things you're going to notice, you can kind of look at it from this picture here as what we're going to be covering. So again, when you have a drug dose being administered, whether it be orally, IV, whatever happens to be, you're going to find there's going to be some period, and assume we're going to oral this for this picture here. But again, there's going to be some liberation of the drug as it dissolves, and there'll be some absorption that happens, right? So if we're talking about oral, it'll be through the GI tract, and then you're going to find you have this central compartment, right? This is really kind of the bloodstream that we're really talking about when we're talking about drugs. So there's different places that the drug can go. We're going to find that we'll talk about free drug versus bound drug. Free drug just means it is not being bound to any sort of proteins or anything, right? Typically, drug that is bound up by proteins is inactive. It is not physiologically active when it's bound to proteins. It's a free drug. It is available to go interact with receptors. It can have its whatever its mechanism is, right? So we're going to find that some portion of the drugs, depending on which drug you're dealing with, may be bound to serum proteins. They may not be. It just depends on the drug. Some of this drug will then go to the therapeutic site of action, the receptors where it actually works. You're going to find that you can also have some of the drug that partitions out into the tissues, right, and just kind of hangs out there and lives there for a while. You may have some drug going to unwanted sites of action, right? So this is where you can have side effects and things that can develop in these drugs. Of course, some drugs are going to undergo biotransformation. This is what we're going to talk about when we talk about metabolism of the drugs, how we get them to inactive formations. And then finally, you have excretion of the drugs. Okay, so we have absorption, we have the distribution about where it goes to in the body, we're going to have the metabolism, and then finally the excretion, how we get rid of it, right? Because do drugs stick around forever in the body? No, we want to get rid of them because, again, the body sees them as poisons essentially, right? Okay, so first off, there's a couple of different ways that drugs can get into past biologic membranes, either to be absorbed through the GI tract or to go through the skin or to be absorbed into the actual cells themselves to get to the site of action. So we're going to talk about this distribution that happens here, right? So permeation, basically when a drug's moving across one of these borders here. So whether it be an intestinal wall, capillary wall, whatever happens to be, blood-brain barrier potentially, this diffusion has to occur. Otherwise, the drug doesn't get to the site of action. It can't really do anything, right? So a couple different ways we're going to talk about this. We'll talk about aqueous diffusion, which is basically just molecules kind of passing through aqueous mediums. This is going to be passive. When I say passive, what does that mean? Yeah, it doesn't require energy. Everything's going along a concentration gradient, right? So it's going to go from areas of high concentration to low concentration. It does not require energy. It just happens passively, right? We'll also talk about lipid diffusion. We'll kind of talk about them together because, again, these drugs have to go into solution, essentially. They have to be dissolved into the fluids of the body. And then to cross these membranes, though, they have to undergo lipid diffusion, right? So, again, usually your cell membranes are going to be composed of these lipid bilayers, right? So, again, normally they're going to have more of a hydrophobic sort of outside and more of a hydrophilic outside and a hydrophobic kind of middle core here. And again, only really lipophilic molecules are able to kind of cross this very easily. Okay, this is just easy permeation. We'll talk about some different forms of transport later on, but this is considered lipid diffusion. The thing you're going to find, and we're going to talk about this when we talk about acid bases and pH and whatnot, is that things that have a charge on the molecule are not going to be able to cross very easily, right? Because again, things that are lipophilic, they're going to bounce off of things that have charges essentially, because as you have a charge, things become more polar and they're more likely to be more water soluble than lipid soluble. So one of the things we'll talk about is lipophilicity versus hydrophilicity, and those are usually going to be counter to one another. So if you have something that's very lipophilic, chances are it's going to be more hydrophobic, and if you have something very hydrophilic, it's going to be more lipophobic, right? Good. And we can modify that, right, based on how we can actually change the pH of the solution that the actual drug is in. So we'll look at some examples of that a little bit later on. So there's also other ways where we have carrier-mediated diffusion. So this is good for things that cannot cross the membranes on their own. So you may have kind of passive channels that will open up and allow things to flow through. That could be one way. Potentially you could also have some carriers, some transporters that can actually facilitate things coming through. Some of these may be active, some of these may be inactive, or more passive, as you'll see. Just depends on the transporter you're actually looking at, right? But again, you're going to find that any of the passive processes are only going to go from areas of high concentration to low concentration. If you want to go the opposite way, that does require energy. That's going to be active transport in order to go against the concentration gradient. Okay. All right, so again, with aqueous diffusion, you're going to find this occurs within the larger aqueous compartments of the body. So between, say, like the central circulation to the interstitial fluid, all of those compartments. This is going to be governed by what we call Fick's law. And so we're going to find that this is dependent on several features, as we'll see when we get into actual law. So basically, we're talking about this diffusion that occurs. I'm not going to have you actually calculate this on any exams or anything. However, I want you to know the concepts and know how if I modify one of these variables, how that will affect flux, essentially. And what is flux? Anyone know? Actually, the diffusion that occurs, right? So kind of that net diffusion that actually happens can also be termed as flux, right? So how much of this molecule is crossing over this membrane, essentially, right? So basically what you're going to find is going to be determined by the concentration gradient, right? So C1 is going to be the amount of drug on the outside of the membrane. C2 is going to be the concentration on the inside of the membrane. C2 should be lower or higher than C1? Should be lower, right? Because again, it's flowing along the concentration gradient. So the bigger the gradient here, what happens to the flux? Yeah, the better the flux, right? So I have a lot of drug on the outside, just a little bit on the inside, it's going to have much more flux than if I were to have, say, a lot of drug on the inside already, okay? Because again, once this passive diffusion is done, you should have equal amounts on either side, essentially, right? So looking at the surface area, if I increase the surface area that I'm applying the drug to the membrane, that does what to flux? Should increase it, good. And the permeability coefficient just shows how likely that molecule, how easy it is to cross that membrane in the first place. So the more, the higher the coefficient, the better it's able to cross. It's going to be very drug dependent. And then it's going to be divided by the thickness here. So the thickness of the membrane has to get across. So a thicker membrane would allow for decreased flux, right? So thin membranes, large surface areas, big concentration gradients are going to drive this passive diffusion, okay? You're going to find this works for both aqueous and lipid diffusion, as we'll see when you're trying to get drugs across these membranes, okay? I'll show you some examples of this just a little bit. And again, as I mentioned, larger concentration gradients, faster diffusion, better absorption. So again, that's why you have areas like the stomach, which again, if you look at the anatomy of the stomach, you look at those microvilli and everything, that brush border it has essentially, it's a huge surface area, and that allows for much better absorption than if we have just a kind of a smooth tube that the drug is coming into contact with, right? So surface area goes up dramatically when you have a surface area like that. And so, again, looking at the thickness of a membrane, you can imagine how different drugs might be absorbed differently between different areas. So, for instance, the skin, probably a lot thicker than a lot of, say, like other membranes, such as, like, say, the lungs, for instance, right? So, again, if I put a lot of drugs on the skin, do they all get absorbed? A lot of them do not, because they don't have the ability to cross that really thick kind of stratum corneum, right? However, if I were to go in the lungs, that's a lot easier to absorb across because it's a lot thinner, right? Again, even if you look at different patients, especially in regards to age, you can find that, you know, who might you think would have very thin skin, kind of underdeveloped skin? Yeah, maybe the elderly or potentially very young, yeah. So if you look at it like an infant, their skin is much thinner. They're much more likely to have drugs cross over their skin than you would see with an adult. So for instance, isopropyl alcohol, right, rubbing alcohol, sometimes can be used as a disinfectant, and they actually, you know, if I were to put isopropyl on my skin, I wouldn't have any absorption. I wouldn't see any problems because I have nice developed stratum corneum. They cannot use that in neonates because if they put it on them, they actually saw they had absorption, and they actually developed hypoglycemia because of that. So just goes to show you certain drugs you cannot use on certain patients because it may actually have absorption when you don't want it to occur, okay?
The amount of blood supply make it different. That the skin has less blood supply compared to organ which has more blood supply.
Yep, yeah. So that'll make a big difference there. So for instance, like the rectum is like highly vascular, so you see a lot of good absorption there. But for instance, if you were to have, say, like an intramuscular injection, and say for instance the patient's hypotensive and they're not really worried about supplying the muscles with blood at that point, they would have a poor absorption. Yeah. So we'll go over some instances of that. So blood supply is a huge determinant there as well. So this picture is nice because it will kind of show you all the factors here. So again, the thicker this membrane is, less flux you have. The bigger the surface area, the more flux you have. And the bigger the concentration gradient, the more flux you're going to have. Okay. Again, lipid diffusion, you're going to find that the big determinant here is going to be how lipophilic the actual drug is. So if it's very lipophilic, it can cross very easily. If it's lipophobic, it's going to bounce right off that membrane essentially, right? And again, we're going to find that pH is going to dictate a lot of that lipophilicity based on the charge of the molecule. And basically what I mean is whether or not it's going to be protonated or unprotonated, right? In this case, our proton is what? What element? Yeah, hydrogen, basically. Yeah. So hydrogen ions are what's going to kind of dictate whether these molecules are protonated or unprotonated. If I add a hydrogen molecule onto a drug, it's going to be the protonated form. If I take that hydrogen molecule away, that's going to be the unprotonated form. Okay, and depending on the type of drug you're dealing with, whether it's a weak acid or a weak base, that will make it either charged or uncharged when it becomes protonated. So we'll look at those examples specifically. And again, I don't expect y'all to be chemistry wizards or any by any means, but again, I want you to at least understand the underlying concepts here. What kind of will dictate whether drugs get absorbed very well or not, and how you can modify things based on where you're at essentially. So anyway, we're going to find that charged molecules, so again, they have a little either plus or minus on them, are going to bounce off of those lipid membranes, because as you add a charge, that you make things more polar, you make them more water soluble, but you make them less lipid soluble, as you'll see. Uncharged molecules tend to be more lipid soluble. They're going to be able to cross the membrane more easily, as we'll see. Okay. This is going to be determined based on the pH of the solution that the drug is actually dissolved in, and also the pKa of the drug itself, right? And so every molecule will have its own pKa. There's also a pKb, but we're just going to focus on pKa here, and I'll show you how we can actually calculate that and determine how much of the drug is charged or uncharged.
Is it action potential? What is pKa?
pKa is basically this coefficient. I'm trying to remember the specific definition. Any science wizards here, or any chemistry wizards? Yeah, we'll look at the Henderson-Hasselbalch equation, but basically every drug itself will have its own kind of pKa, basically, and I'll show you how that kind of equates back to the drugs in just a minute here. Right. Again, even I've glossed over some of the basics of chemistry from back in the day. But anyone remember looking at the Henderson-Hasselbalch equation back in the day? Okay, so I might trigger some PTSD events here, but we'll go over the basics of it, right? Anyway, so what you're going to find is, so you get the acid dissociation constant is what the pKa stands for. So had I just gone to the next slide, I would have been able to answer you much more intelligently. But basically what this is going to show us is that if you have a drug or a molecule that's at the pKa, it's in a solution with the same pH. So again, if I have a pKa of a drug of 7 and I put it into a solution of pH 7, you're going to find that you're going to have 50% of the drug being protonated, 50% being unprotonated. It's kind of in a 50-50 state. And I'll show you why that is on the Henderson-Hasselbalch equation in a minute here. Basically, what you're going to find is when you're dealing with weak acids, when it's in the protonated state, so you're adding on a hydrogen molecule, and again, do you have more hydrogen molecules floating around in more acidic solutions or more basic solutions? In more acidic solutions, right? That's what makes it more acidic, is you're having all those extra protons floating around. So for weak acids, you're going to find that as you get the solution more acidic, you have more protons there. You're going to find that you have more of this the species here of the protonated version that is uncharged. Okay. And again, one of the big things I'm going to harp on here is that like dissolves like. So if you have weak acids in an acidic solution, they dissolve much better and they're going to be much more lipophilic than if it's in a more basic solution. If you put a weak base in a basic solution, that'll have an easier time being absorbed because it's going to be in the more lipid soluble form. So just remember like dissolves like, and that'll get you 90% of the way. Okay. So anyway, if I have a protonated acid, it's going to be the uncharged state. However, if I were to say put it into a more basic solution where I have fewer of those hydrogen molecules, you're going to find them in the unprotonated form, and this is going to be charged. It'll have a negative charge to it. Okay. On the flip side of that, it'll be the opposite for bases, where if I have a protonated base, if I put a base into a more acidic solution, it'll be protonated. It's going to be charged. It's going to have a hard time getting across those lipid membranes. On the flip side, if I put a base into a basic solution, it's going to be the unprotonated state. It's going to be uncharged. Don't let your head spin just yet. I will show you why this clinically actually makes a difference in just a few minutes here, and that'll make more sense to you. So if you're looking at, say, a weak acid here, if you were to put the weak acid into the more acidic solution, you have more hydrogen ions floating around, you're going to find that the equation is going to be forced over to this side here. We have the protonated form that's uncharged. Because it has no charge on it, it can cross a lipid membrane relatively easily, right? However, if I were to say put it into a more of a basic solution where it's going to be in the more charged state, the unprotonated state, it's just going to bounce right off here. That negative charge just will allow it to just bounce off and it doesn't get absorbed. Okay. So looking at this, I can modify the pH of the solution that the drug is in, and I can modify how well it actually gets absorbed, right? So for instance, if I had a weak acid, how could I increase its absorption? Put it in a more acidic solution. Yeah, so I can make the solution more acidic and that had a better absorption. The opposite is true for bases. If I put a base into a more basic solution, you're going to find it is in the unprotonated state. It's going to be uncharged. It's going to cross very easily. And then on the flip side of that, put it into the acidic solution. It's going to be protonated. It's charged. It bounces right off. So where this becomes important is you can actually have drugs being trapped in certain tissues, right, as an example. So for instance, if I have, say, a mother who is breastfeeding, so one of the things you can actually find is that drugs will actually get trapped in the breast milk because of the change in pH from the serum, which serum pH is normally like 7.35, 7.45. The breast milk is a little bit more acidic. So what you'll find is I can have a drug that is, say, a weak base or something. It will go from its normal pH in the solution of the plasma, 7.35, 7.45. It'll cross over, and as it gets into that more acidic solution, more of that drug is going to be in the charged state, where basically it's not able to cross back over. So you can actually have this concentrating effect where the drug gets trapped in the breast milk, and then who gets it after that? The baby, right? So again, that's one of those concerns we have where the baby could have increased drug exposure because mom has all this drug being trapped into the breast milk.
So are we giving this drug, if you give it oral, your stomach is acidic. Won't it get stuck in the stomach instead of going to the bloodstream?
That's a great question. So basically, what you would find with drugs like that is that yes, a lot of them will pass through the stomach where the pH is like 2, right? So again, if you think about typical stomach pH, as it gets into the small intestine, that's actually where the majority of drug absorption occurs. So again, you have the pancreas like dumping a lot of bicarb into the small intestine. That's where the pH is going to rise back up to either neutral, a little bit more basic, and then a lot of those drugs are going to be absorbed at that point. However, a few drugs do get absorbed directly from the stomach because they are weak acids and they have very good lipophilicity when they're in the stomach there. So aspirin is a good example of that. But a lot of things end up getting absorbed more in the small intestine than they do in the stomach, for sure. Of course, some drugs actually get degraded by stomach acid, and so we actually have to protect them until they get into the small intestine. So, for instance, if you ever look at like Prilosec or Nexium or something like that, those kind of over-the-counter proton pump inhibitors, if you look at them, they're capsules with these little tiny beads inside of them, and basically those little beads are acid protected, so that way they can go through the stomach, not get destroyed by the stomach acids, and then as they get into the small intestine, the basic pH there will actually dissolve that coating, and then the drug can be absorbed. So there's sometimes we have to actually modify the dosage form to make it so that the drug survives the stomach, essentially. Right. So looking at basically what we're seeing here is that if you're looking at for weak acids or weak bases, here's the Henderson-Hasselbalch equation. Basically, it's going to be that the pH of the solution equals the pK of the drug, and then you're going to find that you can actually solve for the log of the non-protonated versus protonated. Basically, what that means is if I have a drug that's in a pH, in a solution with a pH that's equal to the pKa, just know there's going to be a 50-50 split between the unprotonated and the protonated form. Okay. But if I can modify that, if I can change it to a solution to be more acidic, more basic, I can find that I can actually make it, I can favor one version or the other. And so one clinical example where we do this frequently is going to be with, say, for instance, like aspirin. So, and I do this from a tox standpoint quite frequently. I have a patient who overdoses on aspirin. One of the ways that we try to get rid of it is through the kidneys, right? So again, we want to, and again, this kind of gets ahead of us in talking about excretion, but one of the things that we do is that we try to get rid of it through the kidneys even faster. The problem with aspirin is that when it's in more of an acidic environment, because again, anyone know the abbreviation for aspirin? ASA. Does anyone know what that stands for? Acetyl salicylic acid, right? So you can kind of already know that aspirin is a weak acid, right? So you can kind of make that inference based on the name. So aspirin, when it's in a more acidic solution, say for instance the urine, which is usually a little bit more acidic in a lot of cases than the serum is, you're going to find it's going to be in a more of this uncharged state. It's going to be more protonated, and then it can be reabsorbed very easily through the renal tubules. It can go right through those lipid membranes, not very easily, and then gets reabsorbed into the bloodstream. That's not what I want it to do. I want it to get out of the kidneys, right? I want to go out in the urine. So what I can actually do is alkalize the urine. I can make the urine more basic by giving something like sodium bicarb, and that will increase the pH, and that will make the weak acid go into more of this charged, unprotonated state, and that will lead it to bounce off those renal tubules. They can't be reabsorbed, and then the patient just pees it out. So you can actually look at the drug levels, and by giving that sodium bicarb, I can actually raise the pH of the urine, and I will see those levels of aspirin drop more quickly than they were previously. That kind of makes sense? So again, this is why it clinically makes it's relevant that we know how this sort of system works. That way, if we can modify the pH of solutions, we understand how that can modify how well drugs get absorbed or not absorbed, as the case may be. Okay. And again, when the pKa equals the pH, you're going to find it's a 50-50 split here. However, if I were to say make a weak acid, put it into a more acidic solution, you're going to find more of it's in that uncharged protonated state. On the flip side, the bases are going to be more in a charged state when they're protonated, and then the opposite is true if you put it into a more basic solution, right? And again, just a good number to remember, and if I put any lab values on a test, I'll put what the average, what the normal ranges are. But a good thing to remember is that serum pH is normally 7.35 to 7.45. It's a good number to know, just so that way you know if, okay, you see a value, the patient's more acidic, like, okay, well, what's that going to do to things like drug absorption or elimination, etc. So anyway, so again, as I mentioned, in the acidic solution, a weak acid is going to be protonated, it's going to be uncharged, and thus lipid soluble. So for instance, aspirin, as I mentioned, being a weak acid, when it goes into a pH of 2, when it gets into the stomach, it's going to be much more in the uncharged, protonated state. It's going to be very lipid soluble. It gets absorbed very easily from the stomach. However, if I were to take aspirin and say, for instance, you guys familiar with like different types of oral tubes? So you can have like an OG tube, so oral to gastric. If I had OD tubes, I had oral to the duodenum, you would see that actually you would have poor absorption of aspirin because as I put it into that basic solution, it's going to be more in this charged sort of unprotonated state. That makes sense? So again, you want aspirin to go just right into the gastric environment because that's where it gets absorbed best. Okay, that's just one example. Okay, and again, don't memorize these numbers by any means, but just know that every drug is going to have its own pK associated with it, both weak acids and weak bases. So, for instance, like phenobarb has a pK of 7.1. Aspirin has a pK of 3.5. And again, just know that if I were to put aspirin into a pH solution of 3.5, 50% of it would be protonated, 50% would be unprotonated. As I were to drive that pH down of the solution down to like 2, like in the stomach, you'd find you'd have a higher proportion of it being in that protonated, uncharged sort of state, and it's going to be have better absorption in those cases.
So when it's protonated, it doesn't decrease the pH of the stomach, or is it affecting the pH?
It doesn't directly affect the pH of the stomach necessarily. It's not like you don't have that much aspirin around to actually affect the thing. You'd have to take a ton of aspirin in order to actually like affect the pH itself. Yeah. Okay, so other ways we can get drugs across these membranes, we can have special carriers. So a lot of these will exist for, say, for instance, drugs that are too big to cross membranes by themselves, or if they have any other way to get across these membranes. These are really important for cell function. So, for instance, like getting amino acids into the blood-brain barrier. Usually the blood-brain barrier is kind of like, you kind of think the CNS is like the Fort Knox of the body, where it wants to keep everything out. And so it's very protective, and so that blood-brain barrier is very good at keeping a lot of that stuff out. But you need some transport to occur here, and that's where these transporters come into play. You can also have things like weak acid carriers in the renal tubules. These are good for things that are usually too large to go through membranes passively. They'll have to have their own special transporters. The thing here is these are not going to be dictated by Fick's law. Because these are reliant on these transporter proteins, they can be saturated. So you can find that with Fick's law, if I'm going across one of these membranes via passive diffusion, as long as I keep increasing that concentration gradient, I can always have more flux. On the flip side here with these transporter mediator diffusion, you're going to find that those transporters can become saturated at a point. So even though I keep increasing the concentration gradient on the outside, I don't have any more proteins there to actually move the drug across. It's going to be a saturable sort of thing there. Oftentimes, if these, especially if they're going against the concentration gradient, do require energy. In those instances, they require ATP usually. Okay, so just one good example of this would be this multi-drug resistance type 1 transporter. Another name for it is called P-glycoprotein. So this is actually a drug efflux transporter. So for instance, if I were to have, say, a drug get absorbed from the stomach, you have the stomach also being lined with these MDR1 transporters that would actually spit the drug back out after it gets absorbed. This is actually an important drug interaction that can occur here, because if I decrease the activity of this protein, you can actually find that drug levels will increase higher than they would otherwise normally do. So for instance, anyone familiar with the drug statins, used for hyperlipidemia, like simvastatin, atorvastatin, like Lipitor? Basically, those have the ability to interact with these MDR proteins. Normally, after they get absorbed from the GI tract, some small amount of it will be spit back out into the GI tract by these proteins, because they're efflux transporters, essentially. So what I can actually find, if I were to have someone who drinks grapefruit juice, that has the ability, with some of these endogenous products in the grapefruit juice, to actually inhibit that transporter. So instead of effluxing it back out into the GI tract, the patient keeps all that drug absorbed. Now their levels will go higher than they would otherwise. You can have things like hepatotoxicity, you can have rhabdomyolysis. They're very important, clinically important drug interaction you can have there with the statins. And again, like, who drinks grapefruit juice on a regular basis? It's usually older patients, right? Because again, usually their taste buds are kind of wearing out a little bit. They need something strong to really like kind of activate their taste buds, and that's why they drink so much grapefruit juice. Like my grandparents used to drink all the time. And I was like, this stuff's disgusting. They're like, no, it's the only thing we can really taste anymore. So I'm like, okay. Anyway. So birth control undergoes a different process, but you're right. So that's going to be a process we'll talk about called enterohepatic recirculation, where basically estrogens, specifically, they will get eliminated through the bile into the GI tract. What you'll find then is you can have colonic bacteria will actually metabolize that and allow the free estrogen to be available again, and then you can reabsorb that. So again, that's a little bit different, but again, the proteins are kind of doing a similar process where you're kind of spitting the drug out. But if I inhibit that, if I stop that process, you can find drug levels can be modified pretty drastically there. But anyway, again, just to show you, like, here's some enterocytes where you have these MDR proteins, or PGP. In this case, that was abbreviated. Again, it would just spit drug back out in this direction into the intestinal lumen, or potentially could either be eliminated through the feces or reabsorbed. It just depends, right? There's another case we'd have similar proteins are working within the bile duct to actually get bile acids and whatnot being sent out. Okay, maybe some estrogens maybe going through some of these transporters here, for instance, right? Okay, so other ways we can have permeation, we have things like endocytosis. What is endocytosis? It's basically it's kind of like a cellular hug, right? So it kind of like grabs the drug and kind of brings it in. Usually this is good for very large molecules and maybe lipid insoluble, right? Because again, basically the cell's just kind of engulfing it and then kind of pinching it off into its own vesicle. So it's able to get in lipid insoluble stuff or things that otherwise are impermeate to the cell. This is good for things like B12 with intrinsic factor, right? This is important for patients who are developing anemia. If they don't have intrinsic factor, they cannot get that B12 absorbed effectively. Or things like iron getting absorbed with transferrin, right? So those are good examples of endocytosis that occurs. That's the only way we can really get those molecules actually taken up by the cells. We also have exocytosis, which would just be the opposite. It's kind of like getting rid of something, usually kind of releasing a vesicle containing either neurotransmitters or ions or whatever it happens to be. This is really important for secretion of things like calcium into the bloodstream, if we're doing things like enzymes from the pancreas, hormones. So that's another common way to get rid of something out of a cell, essentially. Again, you can kind of see this picture here. Again, you probably have a pretty good understanding of endo and exocytosis. Okay, so that's absorption. That's how usually the absorption occurs within the body. An important concept we'll talk about here is called volume of distribution. This is kind of a theoretical number that can be a little hard for some people to grasp at first, but if you kind of keep thinking about it, eventually it'll kind of click for you. Basically what this is doing is it's telling us how far out into the tissues that a drug is going to be distributed, right? So some drugs like to just stay within the bloodstream. They don't like to go far out into the tissues. They stay right there. That would be considered to have a low volume distribution. Some drugs like to go very far out into the tissue. They like to hang out in the tissue to a large extent, and that has a high volume distribution. A good example I will mention is going to be something like THC. So none of you guys have any experience with this, I'm sure. However, where's THC come from? Marijuana, right? So this main psychoactive component. So again, if you have someone who is doing a urine drug screen, because you may have questions like this to come up with your patients to say, hey, I smoked weed a couple weeks ago. I had to take a drug test for work. Am I going to be positive? Right? It's a common question I get. You get it in the pharmacy, you get it in the clinics, you get it everywhere, right? So, anyone know like how long a urine screen will stay positive for THC? Some people say 30 days.
Depends on like how much they weigh.
Yeah, so it'll depend. So it's going to depend on several factors, but one of the things you find is that THC is very lipophilic. Again, that's why they put it into like oils, and that's why they cook with it, like in butters and things like that, and for these edibles, because it's very lipophilic, it likes to go into oils. So typically things that are very lipophilic like to partition out into the fat tissue, like to partition out into the tissues, and so they'll hang out there for a while, right? And so then what you'll find is that based on these concentration gradients and this diffusion, that as the bloodstream rids itself of the THC there, you're going to have this slow leakage, because again, it wants to maintain that equilibrium of THC from the adipose tissue back into the bloodstream, right? And again, I like to use THC as an example because most people kind of think it's kind of fun and interesting rather than talking just specifically drugs. But anyway, but the questions do come up, right? So you have to kind of slow leak from the tissue. So in this case, lipophilic drugs, or in this case THC, has a very high volume distribution, likes to hang out into the tissue. So because of that, if you have someone who has a larger body habitus, they have a lot of adipose tissue, they're very heavy smokers, so they're taking in a lot of THC, they can be positive for 30 days, 60 days, potentially maybe even into 3 months in some rare cases, because they have all this THC built up in the tissues and slowly leaking back out into the bloodstream, which goes out into the urine eventually.
I worked in a toxicology laboratory, and they actually I'm sure you know, can use hair, and they say THC can be embedded in somebody's hair for the lifetime of the hair, I guess.
Yeah, and so that can be tough too, because in some cases you may actually be able to determine when the exposure occurred based on pretty steady hair growth. Maybe grow so many centimeters per day or something. You can kind of dictate. You can do the same thing with like certain heavy metals and whatnot. Anyone know like where they actually got the value? So like when you have a urine drug screen, they're actually the value that comes up as positive for you, because you have small amounts of THC in the urine and it won't show positive until you hit a certain threshold. Anyone know where that threshold actually came from? There was a study done back in I think it was like the 50s or 60s or something, and it was the U.S. military, because they'd have all these Army guys who were showing positive, and they were like, well, I wasn't smoking weed, it was a secondhand smoke. I got it from, I was at a party and I was breathing it in, and that was it. And so they said, okay, we're going to figure this out once and for all. And basically they put this guy into a room and they filled it with so much THC, basically just igniting all this marijuana, and they put just an obscene amount of drug into the air, and they saw what his level was and said, okay, well, if you hit this high, that could be from secondhand smoke. Anything higher than that, you were smoking the marijuana yourself. And so again, it's kind of a funny kind of study. Not probably ethical to do that anymore, but.
Like smoked marijuana and then lost a lot of weight.
Yeah. So you'll find that, as they have less adipose tissue, you may find that they have a lower distribution. They have less basically tissue for that THC to hang out in. So usually people who are a little bit thinner will not not show as positive for long as someone who maybe someone who smoked the same amount. Essentially, you had two people. One was very skinny, one was obese. They were smoking the same amount. The obese person probably would be show positive for longer because they would just have more of that drug actually hanging out in that tissue and slowly leaking out over that period of time.
But you should try to lose a lot of weight then by the time we get the drugs.
If you can lose that amount of weight in the period where you need to take that drug screen, then I say more power to you. I don't know if that would be the effective way. Maybe just don't smoke weed in the first place, and then you never show positive. That's one way.
Like poppy seeds.
Uh-huh.
Is that like an old wives' tale? We like can't eat like poppy seeds because I don't like morphine.
Mm-hmm.
But how many poppy seeds would you have to eat?
I can't. So you can show positive for if you ate enough poppy seeds, you could show positive for opioids potentially. You'd have to eat a lot to get that positive. I could. We could do the studies. We could do maybe that could be part of your graduate research project. Yeah, just feed people varying amounts of bagels. The problem is everyone's going to get all this adipose tissue from eating all these bagels and all these carbs. So then you can do the wheat study and see if they can lose a bunch of weight. And yeah, who knows? Thank you for bringing us back on topic.
So you're saying like it'll stay in the adipose tissue. So does it just like it'll evenly distribute throughout like your whole body within the fat?
To some degree, you'll find that some drugs may like to partition to one area versus another. So, for instance, like digoxin is an antiarrhythmic we use for like CHF and AFib that loves to bind to the myocytes. So, because and basically how we can determine volume distribution is by measuring the level of the drug in the blood, essentially, right? So, again, we can use that as a surrogate to tell us, okay, well, if I give you this much drug, I give you this dose, and then I get a level in the blood. If none of it's in the blood, essentially, a very small amount, then I know all of it partitioned out to the tissue, right? And again, we're going to get into more in detail on this in a few slides. But if I were to measure that, give you the same amount of drug, but all of it's there in the blood, then okay, well, I didn't partition very far out. It's all still there in the blood, essentially, right? So again, that would have a low volume distribution. For instance, like digoxin, though, it likes to bind to the heart. So again, very little of it's in the bloodstream because again, you measure that level as most drugs you measure as like micrograms per ml. The digoxin you measure as nanograms per ml. So very, very low amounts, and it all just bind to the heart, essentially, right? As opposed to going out to other tissues. But generally, you can kind of think about it just kind of being pretty uniform throughout the body for the most part.
So in that case, if you're talking about exhaustion staying to the heart, like that would be the lower volume distribution? So
that was still considered to have a high volume distribution because when you measure the serum sample of the drug level, you're going to find it's going to be very, very low. And I'll talk about why that is in just a few minutes here. Yes, kind of hold on to that thought there. But anyway, so again, just kind of think about it. The more lipophilic a drug is, typically the larger the volume distribution it has, the more likely it's going to partition out into that tissue there, okay? So the way that we actually figure that out is by looking at the volume distribution, usually measured in liters, is going to equal the amount of drug that I put into the body. So imagine for our purposes, you're giving an IV dose of a medication directly into the bloodstream, usually milligrams. You're going to divide that by the concentration in the plasma. Okay. So again, if I have a very high concentration in the plasma, what does that do to my volume distribution? It's going to decrease it, right? Because again, all that drug that I gave is right there in the central circulation in the bloodstream. That shows me that it didn't partition very far out in the tissue. However, if I have a very small amount of drug, a very small concentration in the plasma, what does that do to volume distribution? It's going to go up pretty significantly, right? So again, if I give a very lipophilic drug, I'm going to find that I have a pretty low concentration in the plasma because all of it partition out to the fat and the other tissues there. Okay, makes sense? Anyway, so again, another example would be, say, for instance, I gave 25 milligrams of a drug and I got a plasma concentration of 5 milligrams per liter. I could divide that out, basically know that the volume distribution for that drug is 5 liters. Okay. Now, again, every patient is a different size for the most part, so you're going to find that oftentimes we will, in order to make apples to apples comparisons, I will take like a volume distribution for a drug that I get, I will divide it by the patient's weight. Okay, so that way I get a liters per kilogram amount, and that way I can compare it to different patients. So, for instance, most drugs you're going to find if you look in like your in your references, right? So you guys all did the homework. Everyone did very well. Actually, everyone did very well. You're going to find if you look in the kinetics for the drugs, you're going to find that it has a volume distribution. It'll be expressed as so many liters per kilogram. So then when you have a patient who says weighs 100 kilograms, you can basically multiply that out and get what that patient's individual volume distribution is for that drug. And that way it can be very patient specific rather than just being one volume distribution for every single person, essentially. That makes sense? So again, you'll have to take the patient's weight into account here.
So what does 5 liter signify? Like, let's say if I calculate that number, so what is 5 liter? Like,
so yeah. Right, so basically, and again, it's a theoretical number, so it's saying like how big of a volume would I have to give that amount of drug into to actually get that concentration, essentially, right? So again, you may not, because you may have drugs that have, like, say, at 200 liters, you may be able to calculate that out. The person doesn't have 200 liters of volume they're actually filling up, right? I don't know any patients that are that large. However, that is theoretically how large of a volume you have to put that drug into to get that same concentration. So much of it is distributed out into the tissues, right? So again, it's a theoretical number, but it is useful for helping us to determine how far distributed out the drug actually gets, right? And so this is helpful. So for instance, if I'm hooking up a patient to dialysis because I want to get rid of a drug faster, I want all that drug to be in the bloodstream. I can't do that if all the drug's out into the tissue. It won't pull it off very well. So that's one of those things where if I'm deciding whether a patient needs dialysis or not for a tox purpose to get rid of drugs, I have to have something that has a very low volume distribution, so I know that it's all in the bloodstream and it can pull it off more easily. That's one example there. So that kind of dictates what drugs we can pull off, what drugs we can't with dialysis. Anyway, everyone know what dialysis is? Basically an artificial kidney we're going to hook the patient up to, we can pull things off potentially. Anyway, but the general rule is the high volume distribution means that the drug is very lipophilic and likes to partition to the tissues. And again, kind of think about it at the size of a pool you'd have to fill up with water in order to get the same concentration of the drug you're going to administer. So let's say, for instance, we have two drugs. We have drug A, which is hydrophilic, and we have drug B that's lipophilic. Okay, so drug A likes to be within the bloodstream where a lot of that volume, that water is. Drug B is going to be more lipophilic, likes to be out into the tissues. Okay, so imagine we have two identical twins. They weigh the same amount. They should have the same distribution, should have all the same characteristics. I'm going to give drug A to one of them. I'm going to give drug B to the other. Okay, and let's look at the actual serum concentrations you would get. In this case, we get 50 milligrams, and we're going to get the concentration of drug A for this one twin is 10 milligrams per liter. Okay, so we actually measured the blood, and that was the dose that was the concentration we got. So by dividing that out, we'd see 50 milligrams divided by 10 milligrams per liter. Milligrams would cancel out, you get 5 liters. Okay, so basically I have to give that 10 milligrams or 50 milligrams of drug into a 5-liter bucket to get that same concentration. Yeah, that's why it's theoretical sort of number. For drug B though, which is more lipophilic, let's say the serum concentration I got was 0.5 milligrams per liter. So I gave the same 50 milligrams of a drug, however the concentration is much lower for the lipophilic drug. That's because where to go? Into the tissues, right? So good. So when I actually divide it out, the 50 milligrams divided by 0.5 milligrams per liter, you get basically 100 liters. Okay, so I'd have to give that 50 milligrams, put it into a bucket full of 100 liters of fluid to get that same concentration, which is showing us that, hey, this is distributing much farther out into the body, essentially. Okay. And again, every drug will be have an express volume distribution based on liters per kilogram. So that way you could actually take this number and apply it to your patient to determine what their specific volume distribution is. And again, generally when you're comparing these values to one another, a good rule of thumb is anything less than 1 liter per kilogram is a low volume distribution, which means likes to stay in the bloodstream. Anything greater than 1 liter per kilogram is going to be a high volume distribution. It likes to get out into the tissues, right? So again, you don't have to memorize these numbers, but these are just some examples of drugs you may run into that have varying volume distribution. So for instance, heparin. Anyone know what heparin's used for? It's a blood thinner. It's an anticoagulant we use if patients are having a clot somewhere. A volume distribution of 0.05 to 0.1 liters per kilogram. It's a very small volume distribution, which makes sense. Heparin's a natural product we secrete anyway. It should be in the bloodstream, preventing clots, right? That makes sense. However, you can go all the way down through all these different drugs here. For instance, you have something like digoxin has 2 to 5 liters per kilogram. In that case, because it likes to bind to the myocytes and have its mechanism there. But you can have drugs as far up to something like chloroquine, which is kind of an old school anti-malarial drug, 200 liters per kilogram. Loves to be in the tissue, right? It's a very lipophilic sort of drug in that case. Okay, so again, you can compare different drugs together. And again, as we go through, we'll show you some different examples of how we can modify the patient's condition, and that will change the volume distribution pretty drastically, as we'll see. Okay. So let's do another example here. So let's say we can actually estimate what a patient's plasma concentration would be. So I can say, okay, if I give this patient, who I know their weight, and I know the dose of the drug that I'm giving, based on the volume distribution that's in those drug references like Lexicomp or wherever you looked up your study, Hippocrates, we can actually determine what we think their serum concentration would be. Now, why might that be useful? Because if it's something like a drug that has, say, a narrow therapeutic index, remember we talked about that? Remember, it would be nice if I can know that I'm going to get into a therapeutic concentration without getting into a toxic concentration, or subtherapeutic dose, as the case may be, right? So again, when I'm looking at a patient who, say, for instance, I'm giving them an antibiotic for, say, a MRSA infection, Staph aureus infection, I want to make sure that I get enough drug to kill the bacteria, but not so much that I'm going to kill off the patient, right? So again, you want to make sure you get into that nice range there. So this goes directly into therapeutic drug monitoring specifically, right? So again, this is where it's good to know what the patient's weight is, and that way we know what, in general, what the volume of distribution is for the drug, which we know from previous studies, and they've done it with people. But let's say, for instance, we have a 70-kilogram male. Say we're going to give them 100 milligrams of drug C, and we know that drug C has a volume distribution of 0.6 liters per kilogram, and we're giving this drug IV. So if you see IV, you can just assume the bioavailability is what? 100%. So you don't have to kind of futz with that. So again, what's his estimated plasma concentration? Now, a good rule of thumb, or a good equation that I want you to kind of keep in the back of your mind here, because again, it's not that I need you to calculate this out specifically for a test, but I want you to know that if I modified any of these variables, what is that going to do to the other variables, essentially, right? So in this case, we're going to find that volume distribution equals dose, so dose for administering, over C0. And C0 is just our initial concentration there, okay? And again, in this case, what do we want to solve for? Yeah, I want to solve for C0 in this case, right? So I can modify that. Basically, I can say, well, C0 equals dose over VD, okay? And so here's how I would do that. So how do I get the volume distribution for my patient? I would take that 0.6 and I multiply it by 70, right? Makes sense? That cancels out the kilograms, and I just get the liters left over. So in this case, for this patient, 42 liters is the volume distribution, okay? I know the dose that I gave was 100 milligrams. I'm substituting in that. And then by modifying it, so I solve for C0. And again, this is as advanced a math as we're going to get in this case, which is some basic algebra. We're solving for C0. It'd be 100 milligrams divided by 42 liters. I could estimate that he would get a serum concentration of 2.38 milligrams per liter. Then I can look at that and say, okay, was that too much? Is that too little? And based on reference ranges and maybe put in the drug references, I can say, okay, well, that's just right. That's the right dose for that patient. Does that make sense? Bless you. All right. Okay. So tip for distribution. Well, again, this will come back up as we go into future topics. So just kind of refresh yourself with this as we go forward, because it'll come back up again and again. Next up is metabolism. Yeah, we're actually breaking down the drugs itself, right? So again, we're specifically when it comes to drugs, we're talking about actually how do we get a drug ready for elimination out of the body, essentially, right? So again, usually what metabolism is doing is trying to get a drug either to terminate its physiologic activity or alter it so it's going to be less potent than it was before, right? And getting it ready for elimination, usually either through the bile ducts or more often through the kidneys, right? And so most of the time, you're going to find that most of the metabolism that happens is trying to get a drug more water soluble. The more water soluble it is, the more likely it is to be eliminated through the kidneys and in the urine. Okay, that's a general rule of thumb, but you may find that it may not always be the case. So again, usually you're going to find that these are going to be deactivating. However, in some cases, we're going to find that some drugs actually have active metabolites. That's basically where you break down a drug into another molecule that still has some activity, as we'll see. So that's clinically important for certain drugs. But more often than not, it's going to be broken down into less pharmacologically active drugs or drugs that have no activity whatsoever. Okay. Okay, and I mentioned prodrugs before. Have I mentioned that in our definitions? Right, so what is a prodrug? Yeah, it needs to be activated again. So this is going through the same steps as the drug would be deactivated. In this case, it's actually going through an activation step. And again, it's all the same enzymes you're going to be finding in the liver when we start talking about those. So for an example, an ACE inhibitor, which are commonly used antihypertensive, if I give the drug enalapril, it actually gets converted in the liver to the active form called enalaprilat. Okay, so it has to be converted to that form before it has any activity. Codeine I've talked about before, kind of a wimpy analgesic, but once it gets converted into morphine, that's when it has this more of its activity there. So you can kind of consider codeine to be sort of a prodrug in that case. And I mentioned Vyvanse before, right? Did I talk about that example? Like people are like snorting the ADHD meds. This is one way to get around that, because again, what do you call that process where a drug actually gets metabolized by the liver as it gets absorbed? First pass, right? So if I bypass first pass with the Vyvanse, nothing really happens because the drug's not activated at that point, or it takes longer for that drug to be activated. So again, just some examples of prodrugs and how we can use metabolism to make more active forms rather than just deactivating the drug. So the majority of metabolism happens within the liver. However, it can occur in other places like the GI tract, the skin, the kidneys. But basically, we're using enzymes to break down these drugs. Okay. The goal is to try to get it more water soluble and get it ready for excretion. Again, usually through the kidneys, but maybe through the bile ducts, maybe some other routes. There's a couple of types of metabolic reactions. We're going to talk about two phases essentially. There's phase 1 and phase 2. A lot of students kind of get into their head that, okay, you have to go through phase 1 and they have to go through phase 2. What you're going to find with these drugs is that some drugs may only go through phase 1. Some drugs may only go through phase 2. Some drugs may go through phase 1 and then phase 2. Again, they're not mutually exclusive to one another. We're going to talk about some specific examples, and I'll talk about one in general. The most important one that I want you to know, and I'll mark it with big stars, and I'll make it very obvious that this is the one you should probably know for testing purposes, because this is the most important set of metabolizing enzymes, as we'll see. So anyway. So first one's going to be phase 1 reactions. In general, phase 1 reactions are going to be things that try to uncover some sort of polar site, trying to make the drug a little bit more polar makes it more water soluble, and in some cases it gets it ready for phase 2 reactions, right? So again, we're just usually uncovering something. We're either oxidizing it, we're reducing a drug, we're hydrolyzing it, but in general, you're not really adding any molecules onto it. That's what we're going to see happens in phase 2. The most important one we're going to talk about, the most clinically important one, is going to be oxidation. Okay. So there's lots of different enzyme systems here. So you have things like amidases, esterases, but the one big one we're going to focus on, which is why it's underlined and bolded because it's so important, is cytochrome P450. Anyone ever seen like CYP P450 before? Probably made 1 or 2 mentions of it before, but this is the #1 most important metabolizing set of enzymes within the liver. Okay, when you hear about drug interactions, so things like inhibiting enzymes or inducing them, this is what they're talking about, is these CYP drug interactions. Okay. With phase 2 reactions, you're going to find this is where we're actually adding on something to the molecule, usually to make it more water soluble. So for instance, I may conjugate a methyl group onto it. I may put a glutathione or glucuronide group, or I may sulfate the molecule in order to get it more water soluble and ready for elimination by the kidney. Okay. So, and again, looking at a typical step, you may find that some drugs will actually go through, and again, this is probably more complicated than what we need, but basically imagine a drug is entering into the system here. Here's a phase 1 reaction that's occurring. Some drugs may just be excreted straight from here, right? It may only go through phase 1. Some drugs may go through phase 1 and then phase 2, right? So again, you uncover a functional group and then you add on something to it to make it more water soluble, and then it can be excreted, okay? Some drugs just go through phase 2. It's not going to be, and I'll show you an example of how a drug may go through multiple pathways, as we'll see here. So here's the drug acetaminophen. Don't know the brand name? Tylenol, yeah, Tylenol. Good. So basically what you're going to find, here's the parent molecule. You're going to find this has actually multiple different pathways it can undergo, and this is true for most drugs, is you're going to have multiple pathways for metabolism. So in this case, and again, you don't have to memorize all these steps here, but just understand that drugs don't have to go through just phase 1 or phase 2. They can go through both in some cases. It depends on the drug. So acetaminophen can either undergo glucuronide conjugation, right? So this is actually a phase 2 metabolism, and you see roughly about 2/3 of it can go through that pathway. About 1/3 of it is going to go through the sulfation pathway, again, another phase 2 reaction. However, in some cases, you may have some of it undergo metabolism by CYP P450, and then we'll talk about specific enzymes here, but 2E1 is the one that metabolizes acetaminophen. A small amount will actually go through this pathway, and you can actually get what we call this intermediate product called NAPQI or NAPQI, and basically then that will then be go through a phase 2 reaction where you add a glutathione onto it, and then it can be eliminated through the urine. Okay. So why is this important to understand the metabolism of certain drugs? Well, for my purposes as a toxicologist, anyone know what the main toxicity you see with Tylenol? Liver toxicity. Yeah, you worry about the liver taking a hit. Basically what happens if I take a Tylenol overdose, I take way too much Tylenol, what you can find is you can actually exhaust some of these pathways. So for instance, you may exhaust your glucuronide pathway. If there's more glucuronide groups to add on to the Tylenol, guess what? I can't conjugate it anymore. If I run out of sulfate groups to add on to that molecule, guess what? I can't do anything with it anymore. So what you find is you exhaust these pathways here, and then you actually have a higher proportion of the drug going under this pathway through CYP2E1, and you form a lot of this NAPQI, and this is what actually causes all the liver damage. It will cause a lot of hepatotoxicity. You can see it spill out and cause renal toxicity, cardiotoxicity. It's nasty, nasty subject kind of chemical here. Now, if you can glutathione conjugate it, you can detoxify. However, that gets exhausted too, and then now all of a sudden you have all this NAPQI floating around the body, and that's when the patient can potentially succumb to it. So again, we may give things to try to overcome that by trying to replace some of those pathways, but just know that every one of these pathways can be saturated to a point to where even if I keep adding on more drug, I can't really metabolize any more of it because I've exhausted them essentially. Okay, so just to give you an example how drugs can undergo different metabolic pathways. Again, here's just some examples of other systems that are out there. Again, we'll go into more detail on CYP P450 because that's probably going to be the most important one we're going to talk about through our year here. And I mentioned the first pass effect. That's just the liver tax. So again, as a drug gets absorbed through the GI tract, how much of it actually gets metabolized. And again, it's very variable. It could be a little bit, it could be a lot. It just depends on the patient, depends on the drug, and how much of it gets metabolized by the liver in that first pass there, right? And again, for instance, I can actually change how much. I can actually change the bioavailability very drastically by changing the route of administration, right? So again, everyone's familiar with the drug ethanol, right? How is it usually absorbed? Usually orally, right? Are there any other ways you can absorb it? There's rectally, right? So again, some industrious youths who have more time than sense have tried using it rectally. And so what do you think happened to those patients? What do you think happened to the bioavailability of that alcohol? It went up pretty significantly, right? So then all of a sudden you think, I can handle 2 beers. Let me do this rectally then. And we know the term for that? Don't tell your professor I teach you this kind of stuff, but basically they call it butt chugging is the term for it. I don't recommend it to anyone, right? But again, as a toxicologist, you get calls on this kind of stuff with some regularity. So anyway, what happens is, okay, calm it down. So anyway, what you end up seeing is that they have a lot better absorption of that 2 beers of alcohol than they would have orally. And guess what? Their levels of ethanol go up dramatically. And then guess what? They end up developing CNS and respiratory depression, and they die. So there's been a couple of cases people dying from that, right? There's been cases where, think about like vaginal absorption. That would also bypass first pass. So there's been patients who have soaked tampons and things like that in alcohol and stuck them vaginally to absorb. People have done intraocular ethanol for whatever reason. I imagine that would just burn like a heck. But there's even I've ever heard of like a vapor-tini. There's this device where basically you put hard liquor into this kind of glass globe that you put a tea light underneath, and it will vaporize the alcohol, and you can inhale it. Because again, the lungs very vascular, and you can have some absorption there, right? So again, lots of different ways to do it to bypass the first pass, and that changes the bioavailability dramatically in some instances. Okay. So again, I don't recommend any of these things to you. However, just know that people do lots of weird things, and sometimes they're modifying the kinetics without even realizing it, right? Anyhow. Okay, so looking at the CYP P450 system, again, this is involved in endogenous biosynthesis and catabolism of a lot of things in the body. However, this is going to be the most important system we're going to talk about as far as drugs go. And in fact, over the majority of drugs actually go through some of these CYP enzymes, and we're going to find there's lots of different ones that are available. They're involved in a ton of drug interactions. So whenever you're prescribing a new drug to a patient, make sure you run through to see if there's any of these CYP interactions that pop up, because again, you can cause dramatic changes in the levels of drugs in the body, either causing them to drop dramatically low or get them extremely high and cause a lot of toxicity, as we'll see. So there's more than 1,000 individual enzymes here, and about 50 or so are functionally active in people, right? Looking at these, and again, they oftentimes are abbreviated as CYP P450. You're going to see that. Basically, there's going to be multiple isoenzymes, and so when you see the the letter and the number combination after CYP P450, you're going to find that is what we're referring to as the isoenzyme, right? So it's the individual enzyme. And again, you're going to find that certain ones are specific for metabolizing individual drugs. Some of them are very wide-ranging, and they can metabolize a ton of drugs. Some are very specific to only a few drugs, as we'll see, right? And so we'll see we're going to be classified into families and subfamilies based on the amino acid sequence. So for instance, looking at CYP2D6, you're going to see that basically CYP2D6 is the entire enzyme name. CYP is just referring to the fact that it's a cytochrome P450 enzyme, right? 2 is the family of it, showing how much homology it has with other 2 enzymes, right? D is going to be the subfamily, and then finally 6 is the actual individual enzyme itself, right? And you'll get familiar with your work with some of these drugs of the more common ones you're going to run into, so like 3A4. Number one you're going to run into, right? 2D6, 2E1, 2C9. You'll get familiar with some of these because some of them are much more clinically relevant for drug interactions than others, and so you get kind of familiar as you work with those drugs. And again, if you want to see the chemical process is occurring here, but basically, again, we're undergoing oxidation here to get the drug more ready for elimination through the kidneys usually. Again, just to give you some examples of substrates. Again, substrates just means anything that's being metabolized by that particular enzyme, and different drugs that can be, undergoing metabolism by these different enzymes, right? So here's some of the more common ones you're going to run into. Which one do you notice has the most under its heading? Yeah, 3A4. So again, this is going to be the most clinically relevant one. I'll show you a graph here in just a second to show you kind of the proportion of drugs that get metabolized by 3A4 versus some of the other ones. Now notice you can have inhibitors and you can have an inducer. So when I say an inducer, what do you think that means? Yeah, so it makes it inducers induce. Okay, that makes sense. It actually makes more of the enzyme essentially, right? So it actually makes you have more 3A4 available to metabolize these drugs, right? So if I induce 3A4 and I make more of it, what do you think it does to metabolism of those drugs? It increases, right? So then that would cause levels of those drugs to go up or down. They would go down, right? Because I have more enzyme to metabolize the drug, right? So again, as I induce the CYP3A4, so for instance, if I were to give, say, a barbiturate, something like phenobarbital, to induce 3A4, it would cause levels potentially of acetaminophen to go down. Okay, more enzyme around to metabolize a drug, the lower the levels are going to be. Okay, on the flip side of that, can have inhibitors that will inhibit the activity of the enzyme, and that will cause levels of the substrates to do what? Go up in those cases, right? So again, going back to that grapefruit juice example, if I were to give, that's also a CYP3A4 inhibitor. If I were to give grapefruit juice to someone who's on a drug like simvastatin, or Zocor, for their hyperlipidemia, I will inhibit the metabolism of that simvastatin and cause levels to go up. Levels go up, that's when you see hepatotoxicity, rhabdomyolysis, so some people died from that because of that really relevant drug interaction. So again, when we go through Pharm 1 and Pharm 2, we'll run into those specific examples, and I'll say, hey, don't mix these drugs together because of a CYP interaction. That's what we're talking about, right? Either an inducer or an inhibitor. In some cases, we can actually use these to our benefit. So for instance, if you're familiar with HIV, used to be that the drugs they'd have to take a huge number of pills every single day. They would have to take, 20, 25, 30 pills a day just to manage their HIV. One of the things we actually started doing is combining two drugs together to take advantage of one of these interactions. So basically, there's a drug called ritonavir that will inhibit the metabolism of some of the other drugs that they would be taking for their HIV. So by boosting up the levels of that drug, now they have to take it only one time a day versus having to take it 2, 3, 4 times a day, right? That's one case we can use it to our advantage. Most of the time, though, it's going to be something we want to avoid for the most part, okay? All right, so if we were to look at CYP enzymes here, you notice here that CYP3A4 roughly takes up about 50% of the pie here. So about half of all the drugs you're going to see metabolized through the CYP system is going to be through 3A4. So this one is the most clinically relevant. Other big ones you're going to run into include CYP2D6, 2C9 is a big one, but those are probably the 3 most common ones you're going to run into. But again, depending on the drugs you work with, you may find that will find other ones that are more specific to your particular, wherever you work, whether it be emergency medicine, neurology, rheumatology, whatever it happens to be, right? Here's some of the phase 2 reactions here. Notice it's a little bit more evenly spread amongst them, but again, when talking about CYP enzymes, 3A4 is kind of the king here, okay? Okay, so some other places drugs might be metabolized, things like the gastric acid, digestive enzymes potentially. This is the big reason why we cannot give protein-based products orally, right? So I can't give a diabetic patient insulin orally because that's a protein. It'll get degraded by the stomach acids, right? Or the protein proteases that are places like the pancreas are sending out. That's a big reason why all of those protein products have to be given via which route? Yeah, either sub-Q or IV, right? So again, some sort of injectable sort of route to bypass the stomach, the GI tract essentially, right? In some cases, you may find that the gut flora, so again, the normal microbiome that you have in your stomach, is actually responsible for allowing for absorption of certain substances. So for instance, vitamin K. Some of the colonic bacteria can metabolize vitamin K to allow it to be absorbed a little bit better. And again, you'll find that vitamin K is really important for the liver in actually producing clotting factors. And we'll find that a big drug that interacts with that clotting factor synthesis is called warfarin or Coumadin. I'm familiar with that drug. It's a blood thinner, right? So again, it basically inhibits vitamin K. And so if I were to do anything to maybe get rid of that gut flora, say for instance I give antibiotics, and now all of a sudden I can't absorb that vitamin K, you're going to find that the warfarin effects are going up pretty dramatically, right? So that's one example where you may see the patient starts bleeding or bruising more than they were before because they started a course of antibiotics, right? So again, just an example. Again, don't have to memorize that for our testing purposes, but just know that these sort of things will come up in Pharm 1 and Pharm 2 later on. That's actually the big reason why, if anyone's familiar, oh, yes ma'am.
If Coumadin inhibits vitamin K, why then? What's the relationship with them eating less meat?
Yep. So with warfarin, it inhibits the activity of vitamin K. Basically, it prevents the recycling of vitamin K within the liver. So, and most of your green leafy vegetables have a lot of vitamin K in it. It's like your kale, collard greens, spinach, all of those, right? Have a lot of vitamin K in it. So the thing with warfarin patients, you have to make sure that you're keeping their vitamin K intake stable. So for instance, if I have a patient who is on warfarin, they're at a good stable dose for a while, they're not having any clots, they're not having any bleeding, and then all of a sudden they say, well, I'm going to go on an all spinach diet. I'm going to spinach morning, noon, and night. That's all I'm going to eat. Get a ton of vitamin K coming in. That's actually going to make the warfarin work less effectively because now I have all this new vitamin K around, right? On the flip side of that, if I have someone who says, okay, well, I'm not going to eat any more spinach. I used to eat it 3 times a day, and I'm done with that, and all of a sudden their vitamin K intake goes down, now the warfarin works even better, because there's less vitamin K around, right? So then the patient may be more likely to bleed. And so this is the big thing I ran into. So anyone familiar with Putnam County? I mentioned, yeah. So again, no one's ever heard of it. So I remember when I was going to undergrad in Jacksonville, I had one guy that was up at the front, like big orientation, probably like 300 or 400 people in the room. And some guy's like, anyone ever heard of Interlochen, Florida? And I was the only guy in the way back of the room. I was like, yeah, woohoo. He's like, no one's ever heard of that place before. And I was like, I'm the one. Anyway, but I did my first rotation there in Palaca, and we're doing a Coumadin clinic basically, and so like that was most of what our patients ate because a lot of them were growing their own collard greens, their own kale, all this stuff, and so like that's a big education point. Is okay, well, how much vitamin K are you taking based on their diet, and make sure they were keeping that stable because if they modify that dramatically, guess what? Warfarin either worked too well, they started bleeding, or it didn't work well enough, and then they started potentially get a clot. Yeah, so that's a big deal. Warfarin's we'll talk all about warfarin later on, but it's a big deal. Anyway, so just know that whenever you have a significant hepatic disease, this can affect how well you can metabolize these drugs, whether it's alcoholic hepatitis, cirrhosis, anything like that can affect how well you can metabolize those drugs. It may lead it to have less metabolism overall. Okay, other things like acute renal disease, diabetic nephropathy, all these things could potentially also lead to some issues where we may not be metabolizing drugs as well. And then also cardiac disease. This one's kind of interesting because if you look at blood flow through the liver, if I decrease blood flow, what do you think that does to metabolism? It's going to decrease because I'm not getting the drug to the liver to get metabolized in the first place, right? So again, I'm not kind of lacking on the supply side rather than the demand side, essentially. So if you have anything slowing down delivery of blood to the liver, in this case something like CHF or something, or cardiac disease, you may actually have to reduce the dose of your drug to account for that decreased metabolism. So a good example would be someone getting lidocaine, which is sometimes used as an antiarrhythmic for CHF patients. I actually have to cut the dose in half to make sure they don't get their levels too high because I know they're not metabolizing as well. Okay, just one example. Okay, some other cases we may find that metabolism can be affected, so things like the endocrine system. If I have someone who's hypothyroid, what does that usually do to their metabolism overall in the body? Usually decreases. That could also lead to decreased metabolism of drugs. On the flip side, hyperthyroidism, you expect that to increase in some cases. Genetic factors, so again, I mentioned some people express too much of certain enzymes and too little of others. You mentioned certain patients have a lot of CYP2D6, and they metabolize a lot of codeine and morphine. Some don't do that so well, right? So again, it all depends on genetic factors. Diet can be a big deal here. For instance, I can have things that induce some of my CYP enzymes. So again, everyone had a good 4th of July, I hope. Anyone eat any barbecue or smoked food? None at all? What's that? Studying farm. Okay, well, you can have a hamburger and study farm. But if you had any kind of charbroiled foods, you would find that I could actually induce certain CYP enzymes. You may actually have more of those enzymes available to metabolize drugs, right? You may metabolize all the caffeine you're probably intaking to study for the farm test, right? Anywho, but you got things like grapefruit juice, as I mentioned, is a very potent inhibitor, especially CYP3A4. That's responsible for a ton of drug interactions, especially for your older patients who, older patients on fewer or more drugs usually. They're probably on more drugs anyway, so they're probably already having a bunch of CYP interactions to begin with, and adding on grapefruit juice can be kind of a sticky problem there. Age and gender can affect this pretty dramatically. We'll see more of that when we get into the GERI and the pediatric section later on. And again, any disease decreasing blood flow to the liver is going to decrease metabolism overall. Okay, so a couple. See what I can get through. Anyway, so as far as drug elimination, here's how we actually get rid of it out of the body. Usually you're going to find that renal elimination is going to be the most common one, but certainly through the biliary tract, out into the GI tract, and then eliminated through the feces, right? So again, some drugs will be eliminated through the feces there at the end. So anyway, you're going to find that a lot of these drugs, and again, as we make them more water soluble, especially through metabolism in the liver, you're going to make them more easily able to be filtered by the glomerulus and then eliminated out through the urine. Again, you may find that things that are very lipid soluble are actually going to be reabsorbed through the renal tubules very easily. So that's why I mentioned with the aspirin example, by putting it in a more a lipophobic sort of state, a more hydrophilic sort of state, they're easier to get rid of in the kidneys. Okay. Again, normal urine pH is anywhere between 4.5 to 8, because again, that has a pretty wide range here, because the kidneys are really responsible for helping maintain acid-base status in the body. So you can find that can be pretty wide-ranging. However, just know the charged molecules are going to be readily eliminated because they cannot be reabsorbed through that renal tubule, right? Because they're less lipophilic at that point. Again, weak acids are usually going to be excreted faster in more alkaline environments, as I mentioned, right? So again, if I were to increase the pH of the urine up to say 8, you're going to find the weak acids are going to be more in that unprotonated state. They're going to be more charged. They have a harder time being reabsorbed because they have the charge on. They're just going to bounce right off those membranes there. So that's one way we can actually modify how well a drug either gets eliminated or potentially hold on to it in some cases. Weak bases are usually going to be eliminated faster in acidic urine because like dissolves like, and here we're actually putting it in the opposite, right? So we're putting a weak base into acidic solution to make it more easily able to get rid of it. And then I mentioned the trapping effect you can have, where if you change the pH as a drug partitions to a membrane into another solution that has a different pH, you can find that trapping. I mentioned you can see this in breast milk, you can see this in vaginal secretions, aqueous humor, all these different places where drugs can be potentially sequestered based on that change in pH that occurs there, right? Okay, so I mentioned with aspirin as the example, it's a weak acid. As I increase the urine pH, I'm going to have a higher charge fraction. More of it's going to be likely to bounce off those membranes and just be eliminated in the urine rather than be reabsorbed as you would see in more acidic urine. Okay, so looking at clearance of drugs, basically you have to look at it as kind of all the different ways the drug can be eliminated from the body. You kind of add them all together essentially, right? And so you can see that when you're looking at the clearance total, you're going to be including the renal clearance, liver clearance, biliary, and any other things, right? Some drugs may be eliminated to small amounts of the respiratory tract, just depends. But again, you're looking kind of clearance overall and looking at it in the amount of drug per unit of time. So usually in mLs per minute, right? So how many mLs of blood am I clearing per minute of this drug essentially? And so what we're going to find is that clearance is really important in determining our drug concentrations, right? So if I have more clearance, what does that do to the drug levels, do you think? Decrease it, increase it? Should decrease it, because if I have more clearance, I'm getting rid of it, right? Something like clearance sale, and or all the Toys R Us's that are going out of sale, right? They kept lowering the prices, they're increasing the clearance and getting rid of all that stuff. Versus if I had lower clearance, that would do what to drug levels? That would increase the levels, right? Because again, I'm clearing less of the drug, more of it sticking around essentially. That's important when we start talking about things like half-life and talking about how long drugs are sticking around in the body essentially. So anyway, one of the big things you're going to see as far as renal elimination of drugs is we're going to be estimating this with our creatinine clearance. You guys familiar with this? Have I mentioned this already? Probably briefly. Basically what we're going to do is that, where do we get creatinine from in the first place? Yeah, from the muscle breakdown, right? Creatine gets broken down in creatinine. Creatinine is nice to estimate renal function because it is freely filtered by the glomerulus, but it doesn't really get reabsorbed or secreted in any large amount. So again, what I know gets filtered to creatinine, what I measure out in the urine would tell me, okay, yes, this is basically what the glomerulus is actually filtering. That's the GFR, right? The glomerular filtration rate. However, you can measure someone's urine for 24 hours to get all that creatinine that they're excreting. Is that really practical though? Have someone go around with a big bucket and collect all the urine all day long? Not really, right? So no one wants to do that. So oftentimes what we'll use is use a serum creatinine as a surrogate marker there, right? So we can use the serum creatinine as a placeholder for that and put it into some of our equations to determine what the renal function is for the patient, right? So again, when we determine creatinine clearance, this is trying to be an estimation of what the actual GFR is, right? So usually you're going to find that they're kind of used interchangeably. So typically, creatinine is 0.6 to 1.2, depending on the patient you're dealing with. And again, some of the features here, and again, this is just one of the more common calculations we're going to use to determine creatinine clearance for our patients. This is called the Cockcroft-Gault equation, and this is something that we use very commonly for determining the renal function of a patient. This is good for like healthy adult patients, typically, and trying to determine what the renal function is, right? So some of the factors here I want you to kind of note, and again, I'm not going to have you calculate this on the test specifically, but know how the different variables are going to affect the creatinine clearance, okay? So anyway, so notice age. What do you think age does to our GFR and our creatinine clearance? The older the patient, probably decrease, right? We just know that renal function is going to go down as patients get older, as their organs start to wear out. So in here, you're looking at the difference here. So again, as the value, the age gets higher, what do you notice about this in the numerator? The difference is going to be smaller, right, between the one, because you're doing 140 minus the age of the patient, that it gets smaller. So as they get older, the creatinine clearance should go down in this case, right? Versus a younger patient, 20-year-old is going to have a lot higher creatinine clearance than an 80-year-old, okay? Because that difference here is going to be a lot smaller for the older patient. Next, we multiply by the weight in kilograms. And again, most of you guys are probably used to doing things in pounds, but in medicine, get used to doing kilograms, right? How do you convert pounds to kilograms? Divided by 2.2. That's a good conversion to keep in mind. I usually recommend people just start using kilograms now just to get used to it, because again, if you start using them interchangeably, that's where errors can happen there, right? So again, if I have a patient who comes into the ER, peds ER, and the parents say, oh, they're 10 pounds, and I accidentally mishear that, and you go 10 kilograms, guess what? Doses are going to be way off for that patient, right? So we want to get really used to using one or the other. And kilograms is the standard one now. Anyway, so you're going to times it by their weight. So again, this is going to go back to, we mentioned that creatinine comes from muscle. So presumably the heavier the patient is, the more muscle they should have, right? Is that always the case? No, absolutely not. So again, there's some limitations here, as we'll see. However, usually the more weight, usually a little bit more muscle. So again, that should account for that. So the bigger the patient, creatinine clearance should go up, right? So then you're going to divide that by 72 times the serum creatinine. So again, this value here, so the higher the serum creatinine is, which shows that I'm not filtering it very well, should show me that creatinine clearance is going down, right? Because it's in the denominator. So the bigger the serum creatinine, the lower the actual creatinine clearance is going to be, because I'm holding on to it all, because I'm measuring this from the blood, right? On the flip side, if I had a very low serum creatinine, this will make my denominator smaller, which should make my creatinine clearance higher, right? Good. So that's why that's in the denominator there. And then you'll notice you multiply it by 0.85. Anyone know how I do that for women? Generally, on a weight per weight basis, you typically find females have a higher adipose tissue content, a little bit less muscle mass, right? Now, does that hold true for all female patients? Absolutely not. You have some very beefy bodybuilder ladies out there, and they have a ton of muscle mass. And so again, this is based off of an study they did years ago, right? And again, they didn't take into account every single type of patient out there. So there are limitations. However, this is in general how I want you to kind of look at this to know the different variables and how it's going to have an effect on the creatinine clearance. So the higher the creatinine is, the lower their creatinine clearance is going to be, right? The lower their renal function is. The older the patient, usually the worse their creatinine clearance is going to be, the worse their renal function, right? These are things that kind of want you to get in the habit of looking at. Because when you're looking at drug dosing for your drugs, you're going to see that there's a section just for renal impairment. So you can see based on creatinine clearance, if they're greater than 100, you dose like this. If it's 60 to 100, you dose like this. And if it's less than 30, you dose like this, right? So by looking at that, you can make sure you're dosing just right for your patient. Yes, ma'am.
So the adipose tissue, like increasing in women, is going to cause a lower creatinine.
No, usually because they have more adipose tissue as opposed to having more muscle mass, essentially, right? So again, usually those female patients will have a little bit less muscle mass. At least on the study they did in these patients, they found when they made this model, they found that by multiplying for women by 0.85, based on the fact that they probably have a little bit less muscle mass, that's how they were able to get that to work for female patients, right? Because again, when they do these type of studies, basically they would do something like a 24-hour creatinine collection, and then they try to correlate that with the serum creatinine and try to get the equation that best makes those match up. And so for women in that study, that's what they found to actually be the case. So if I redid the study nowadays, maybe it would be different, but this is kind of historically what we've kind of been working off of.
In general, so like more fat in someone is going to cause a lower creatinine.
The fat doesn't cause lower creatinine, it's just the lack of muscle mass, right? So the less muscle mass there, right? And of course, lots of limitations here. So for instance, if I have someone who weighs 400 pounds, are they likely to be 400 pounds of muscle? Probably not. Probably a lot of adipose tissue. So there's some ways we can modify that. It's kind of outside of our scope right now. We just know some limitations. Imagine if you have someone who has, say, an amputation, say, they have bilateral below the knee amputations. What does that do to the serum creatinine? Probably lowers it because they have less muscle mass now, right? They have missing 2 calves. They're not going to be able to produce the same amount of creatinine. So that would actually falsely elevate their creatinine clearance because they have less creatinine there to measure. So we may actually falsely overestimate what the actual renal function is in those cases, right? So there's kind of some limitations there. But and again, you're going to find there's specific equations for children, specific equations for elderly patients. But again, this is good to at least look at the variables and see how that will affect your patients, right? Okay. So let's go ahead and cut it there. Any questions I can answer before I let you go? Yes, ma'am. I'm sorry if I skipped over you. So you can find that if patients take creatine supplements or they take like a high protein diet, they can actually have a falsely elevated serum creatinine because they actually are breaking down more of that into the actual creatinine itself, if that's a possibility. Any other questions? Okay, so I'm going to go get the test results. I'll look at it and validate it. If there's any givebacks or any high misses or anything, I'll address that in a course announcement. I posted the homework assignment for, because I knew I was going to have some time cut out of this lecture, I went ahead and gave you 2 weeks to do it. So this assignment will actually be due the day of the next test. Okay, so you have 2 weeks work on the homework assignment. You probably won't need that amount of time, but I figured I'd give you a little extra time so we'd have next week's lecture. Yes, sir.
I had a question from the homework assignment.
Yes.
It asked about a drug interaction involving altered metabolism of the drug.
Yep.
Would that be where it's like the liver impairment dosing?
So that would be more like if you have a CYP interaction. So for instance, if you have something like inhibits the metabolism by inhibiting CYP 3 or 4, right? That would be an interaction you want to kind of look for that.
Where, because I was trying to look, I didn't see anywhere to find that kind of.
Yeah, so if you look in places like Lexicomp, so if you were to go through up to date and get to Lexicomp, most of you guys are able to find that. It looks like most of you use it for reference. That'll have a whole thing where it says like, okay, here's what happens if you have a CYP3A4 inhibitor on board or whatnot. That's one place, the package insert for the drugs itself. So there's a website called DailyMed. If you just Google DailyMed, that actually links to every single package insert that is available for U.S. Approved drugs. That may be another good place to look for it there as well. Yes, ma'am.
I don't know, some people might be upset that I'm asking, but like,
how dare you?
Are you going to be lecturing until 11 today?
I am not today. So
okay.
I'm sorry that was not communicated. I got the message yesterday from Dr. Murray that I would just be going till the normal time. So I'm done for today.
So on normal tests, there's going to be less than.
So the next test, it'll be just like now, as far as I know. Okay. So that was a last minute kind of update for me as well. I found that out yesterday, so I apologize for the mix-up. You guys won't mind getting out an hour early, right?
So for the next test, you want us to come at 10:30 so we can have more time for this class?
No, it'll still be 8 o'clock. I think it has to do with like registrar stuff and stuff out of my control. So just come at the same, so 8 o'clock, same like you did today. Okay, and we'll try to finish up right around 10. Okay. Any other questions or anything? No. All right. Well, enjoy your. Yes, ma'am. Yeah, I'm gonna get through what I can. Yeah.
Okay.
Yep. Yep. Cool. Thank you.